Thank you, Karen. I think we've probably still got a few people left to join, but it's just gone 2 o'clock and we've got quite a packed agenda today, so I'm going to make a start and we'll just let people join during that. So welcome everybody today to the South East Homelessness and Inclusion Health Network. My name's Sarah Rayfield. I'm a public health consultant in OHID's South East team. So Tracy Dashkowitz, DPH for Berkshire West, normally chairs these meetings, but unfortunately she was unable to make it today. So I'll be chairing in her absence, ably assisted by Karen as well. And welcome particularly to colleagues who perhaps don't normally join these meetings, but are joining as it is a special focus on children and young people today, and particularly focusing on those children and young people who are either experiencing or at risk of homelessness. So in terms of the kind of agenda for today, we've got a couple of updates as usual. So from DLUC, NHS England, and then ourselves OHID and the UK HSA update as well for the South East. And then we're moving into our speakers, and we've got 3 kind of sessions, 3 presentations by some colleagues who've really kindly joined us today, particularly to kind of focus on this issue of children and young people. So we've got Emma joining us from the Shared Health Foundation, giving us an update from the All-Party Parliamentary Group on temporary housing. Then Tanja and Zoe are joining us from the Healthy Child Programme in Sussex to give us a first-hand perspective of the effect of homelessness on families and children. And then Hannah will be joining us in a bit, the CEO of Career Matters, and she'll be giving us a talk around the pitfalls facing care-experienced young people and considering what can be done to support them with housing and employment. And following on from those sessions, we're going to do some group work, kind of reflecting on what we've heard and what we might want to think about taking forward as a network for next year. But just to say, I think the point of today is really very much the beginning of the conversation and scoping out what we think the issues are, local challenges, opportunities, and where we can work together. So it's very much the beginning. Yes, so without further ado, where's that hand? No, it's gone. I think as Karen touched on, but maybe perhaps before some people joined, if there's any if anybody has a question, please do pop up your virtual hand or in the chat box, and yeah, and otherwise normal Teams meeting etiquette applies. Fab. So we will, unfortunately, Jane, who normally Jane Cook, who would have been our DLUC representative, was unable to make today. So she gave us some slides to give an overview of the new rough sleeping strategy. So I'm just going to present them on her behalf. If we've got any questions following that, then happy, we'll try and answer them. But if we can't, we will pass them on to Jane and get a response as well. So just to highlight that the rough sleeping strategy was published recently, the updated version. And within that, it includes the vision and approach to, number 1, to better prevention, so to reduce the number of people that reach the streets in the first place. So number 2 within the strategy is around a swift and effective intervention for those who do sleep rough. Number 3 is additional targeted support for those that need it for their recovery, and that includes specialist accommodation when needed. And then number 4, a more transparent and joined up system, and this is around ensuring that everyone is working together effectively. The framework for housing is also relevant to healthcare planning and delivery. And then a few things of note in terms of funding. So up to £500 million of rough sleeping initiative RSI funding is available to local authorities across England. And this spans a 3-year period from April of this year to March 2025. The rough sleeping drugs and alcohol programme provides up to £186.5 million funding for expanding this drug and alcohol treatment into a total of 83 local authorities. And then finally, we have 30 million of funding for specialist mental health provision for people experiencing rough sleeping in 23 high need areas. We can, yeah, fab, thank you. So just towards the end of November, so very recently, there was an update from ONS, the Office for National Statistics, and that's the recent data on deaths of people experiencing homelessness in England and Wales. So that update showed that in 2021 there was an estimated 741 deaths registered, and this was an increase of just over 7% compared to the year before. And in terms of the breakdown of causes of those deaths, just over a third, 35%, were related to drug poisoning, 13.4% were related to suicide, and 9.6% were alcohol specific. The vast majority of the deaths were in men versus women, so 87.3% of deaths were in men, and 18% of all male deaths were in those aged 45 to 49 years, so that was the most common group. And in terms of female deaths, the most common were within the 40 to 44 years age group. And the mean age of death for women among homeless women was 43.2 years. Thank you. And then just here to show kind of from a regional perspective where we sit in the southeast compared to other areas. And actually we have the third highest number of deaths, or had the third highest in 2021. So this is the number of deaths, and these are deaths that were registered that year. So London had the highest, followed by the northwest, and then here in the southeast as well. And you can see how we relate to other areas as well. If we could, yeah, thank you. And then this graph just shows the trend really for each regional area across England. As you can see, England, and again, this is the rate of deaths amongst those experiencing homelessness. And in England, there's been a steady incline, but that sort of varies across area by area. Southeast is on the bottom row of this set of graphs, and we've kind of continued along the same sort of trajectory. We're not sort of making huge progress, but things aren't worsening either. And you can see how that varies compared to different areas across England as well. Thank you. So just a quick word about cross-government commitments, where DLUC is leading in this. So there's a strong cross-government approach with an emphasis on ensuring that those leaving a public institution don't find themselves on a street. And so the new strategy includes a range of commitments from colleagues in across government. So DLUC will be working with the Home Office to reform the rough sleeping support service. And this includes a commitment to pilot improved support to explore what more can be done for those who wish to return home. There's a new employer covenant from DWP working with the Crisis and Refresh Job Centre support. And then there's work with Department of Health and Social Care to ensure that the new integrated care systems develop joined up local strategies that bring together housing, homelessness and healthcare. And this will include new statutory guidance on the duty to cooperate on health inclusion. And then there's strong links to the Ministry of Justice reducing reoffending agenda, and that includes continuation of the CAS3 programme and further DLUC funding for the AFEO programme. And these are both programmes and initiatives that support prison leavers with providing accommodation on leaving prison if they're at risk of homelessness. And then the link at the bottom is the link to the new strategy, which hopefully most people on the call have seen already. Thank you. And I'm going to hand over to Olivia to give a brief update from NHS England in the South East. Thank you.
Thank you, Sarah. Good afternoon. So not much from us, I think, just 3 or 4 verbal updates. The first one is continuing the work we're doing on supporting systems with developing bespoke mental health services for people who are homeless or rough sleeping. Each one of the 6 ICS has received some transformation funding. So for some of them, it's strengthening the services that started last year or the year before. For others, it's implementing and hopefully having something in place by Q4 of this year. We're expecting, as part of the operational planning round to start just before Christmas, that the funding that was committed up to the end of the long-term plan, so up to the end of 23-24, will be reconfirmed. So that work is ongoing. And part of our work is obviously to bring together the different agencies that create a wraparound offer around this cohort of people to optimise funding and resources. The second update was regarding COVID-19 vaccination. We have been receiving monthly updates, but we're waiting for the regional update for November. But I'm not sure that the data is as reliable as it has been, as colleagues through multiple pressures in system might not be collecting the data as regularly as they have done in the past. Number 3, I just wanted to signpost to the launch of the Southern Gambling Clinic, which started in Southampton at as of the 1st of September and has now opened up to the whole of Hampshire, Isle of Wight. So by Hampshire, it's Hampshire County boundaries. So there's a part of Frimley ICS. The reason I'm flagging the opening of the gambling clinic is that it's twofold. The clinic will develop towards a regional footprint into next year, so that it serves the whole of the southeast. But each one of the clinic in each region has a specific cohort that they've agreed to focus on, because there is very little evidence base in the gambling space. So for the Southern Gambling Clinic, the cohort they're focusing on is homeless people. So we will try to make the links between the clinic directors and our colleagues who come to the operational group. And then just to add, so we had this last network on how to contribute to the integrated care strategies that are due by the end of December, and how to represent the needs of these cohorts into these strategies. Our colleagues who lead on mental health have partnered with the Centre for Mental Health to provide a bit of a grid. So it's focused from a mental health perspective, but it does include people who are homeless and rough sleeping in terms of how to make sure mental health is duly represented and different cohorts are duly represented in the integrated care strategies. That's all from me, Sarah. Thank you.
Thank you, Olivia. And just before I give our update, does any questions on either of the first 2 updates? Okay. Please do pop anything in the chat or pop a hand up if there's anything you wish to ask. So just briefly from an OHID South East point of view, so the main thing from our side to update us on is that work is continuing on evaluating our multiple exclusion framework. Hopefully most colleagues on the call are familiar with the framework that was initially developed in 2020 and specifically focusing on COVID and transition planning. So we're doing a piece of work at the moment to evaluate that framework and to understand the impact that it's had on work that's happened around supporting homelessness across the southeast, and then the work of that evaluation will feed into the development of the refreshed framework. And the plan at the moment is that the new framework will have a broader remit than homelessness, and hopefully will include wider kind of inclusion health groups as well, and it will be broadened out to be beyond COVID as well. So there's a task and finish group that has been set up to progress that work. We had our second meeting first thing today. If you're not involved in that, but that's something you'd like to be part of, then please just let us know. It's definitely not too late. And otherwise, there will be a survey coming out soon once the questions have been finalised. So just a gentle plea to everybody who's been involved or used the framework to make sure to respond so we can really understand the impact that it's had, and also gain colleagues' views on what the refreshed framework should look like as well. I think that's it from an OHID perspective, unless Karen, you've got anything you wanted to add? No. And so just to update on behalf of our colleagues in Uxbridge, so David Roberts, who's a health protection consultant, provided this update. Unfortunately, he's also on leave this week, so unable to attend the meeting, but similar to the DLUC update, if anybody has any questions, we'll try and answer them or feedback to ACSHA colleagues for a response if we can't. So from an ACSHA point of view, the two main things that they wish to update the network on are the cold weather plan for England, and then just a brief update on diphtheria cases among asylum seekers as well. So it will come to no surprise to anybody that we are having very cold weather at the moment. And so the cold weather plan is in place every year, supported by ACSHA's cold weather alerting system, and that is operated by the Met Office. So the Winter Preparedness and Action Programme, which is level 1 of the 4 alerts outlined there, runs from the 1st of November until the 31st of March. You can receive updates if you register your email address. And the cold weather alerts are then cascaded to a range of health and social care organisations, as well as through ACSHA regions. And there's 5 levels. The lowest level 0 is around long-term planning, which is in place all year round. From the 1st of November to 31st of March, we move into level 1, which is essentially around preparedness and action. Level 2 is alert and readiness, which is when we have a mean temperature of 2 degrees or widespread ice or heavy snow within 48 hours. And then level 3, which we've been in this week, is the severe weather action, where we have a mean temperature of 2 degrees or less and widespread ice or heavy snow. And then level 4, the top level, is around emergency response. And that's if it's declared in the event of a cross-government assessment of weather conditions. Thank you. And then there's links on these slides, which we'll disseminate after the meeting today. So there's links to the action cards, and that really outlines different advice for organisations and how they need to respond to the cold weather alert levels. And these are based on VCSE, providers, health and social care, and also individuals themselves. And then there's a link to top tips for keeping warm and well this winter, and this combines advice from both ACSHA, Age UK and the NHS, and covering issues which are obviously extremely pertinent this winter, looking at financial help, healthy lifestyles, and also encouraging flu jabs and managing heating. And there's various links for information and a poster that can be printed out if useful. And then just a quick update on diphtheria cases among asylum seekers. Colleagues may be aware of this reporting in the national news. So diphtheria is a very rare disease in this country usually, and we have high vaccine coverage. However, we have had increasing cases reported among asylum seekers in England in this year. Most of the cases have had onset of symptoms prior to arriving in the UK, which does suggest that either the disease was contracted at the country of origin or during an extended travel route through Europe. There have been many challenges for individuals arriving at the initial reception centres, and contact tracing is very challenging as well. And so therefore it has been recommended that there's mass antibiotic use and vaccination of residents within these initial reception centres. And the Home Office is working closely with the NHS and other partners in order to implement these recommendations. Guidance has been produced by ACSHA. Oh. Sorry, not sure what happened then. And there's a link in those slides that you'll get. But then also just to mention that the risk to the public is very low because we do have high coverage within our population normally. However, any staff, frontline staff or healthcare workers who are involved in the care of recent asylum seeker arrivals should ensure that they're up to date with their own vaccinations as well. I think that was it from the ACSHA update. Does anybody have any questions or comments? Joke. As I said, please do feel free to pop stuff in the chat. But otherwise, we will move on to our main speakers. And so first of all, we have Emma Roe, who's joining us from the Shared Health Foundation. And Emma is giving us an update on some of the work that they've been doing around the impact of temporary housing on families, and the work they've done around the development of the gold standard protocol for families in temporary accommodation. But thank you so much to Emma for joining us today, and I will hand over to you.
Thanks, Sarah. Karen, are you able to share my slides, or do you want me to bring them up?
No, I will do this now for you.
Thank you for that, Karen. Some nods, good. So my name's Emma Roe. I'm from the Shared Health Foundation, and I'm joined on the call with two of my colleagues, Angie Watara, who is our maternal health lead at Shared Health Foundation, and also Ishkia Wise-Martin, who has worked on the APPG that I'll be talking about today. And so, sorry, the next slide, please, Karen. Thank you. So we are a foundation that was funded by the Oglesby Charitable Trust, and we were created to try and address some of the health inequalities that are seen across Greater Manchester. Thank you. So we were given quite free rein to be able to be innovative. We're a clinically led team with lots of different projects, and one of those that I'll be speaking to you about today is the All-Party Parliamentary Group for Temporary Accommodation, with a specific focus on children suffering homelessness. Next slide, please. So our main goals as a foundation, we really believe in co-production to really understand people's needs, and we try and work with people on the ground at a local level to try and research and work out what the issues are to be able to develop policy and change policy at a strategic level locally and nationally. We also recognise that healthcare professionals often aren't equipped or prepared for working in areas of health inequalities, and so we try and mitigate this. We've got a GP trainee scheme that I'll mention on the next slide and go into a bit more detail. And we also try and improve the knowledge and management of health for both families and professionals, but ultimately try and reduce the impact of poverty on health inequalities. So we've got 4 main projects and lots of other things that are going on alongside that. So we've got the Homeless Families Project, which I'll talk about today. We have the Lemonade Project, which is a training resource and set of material that is available around children and young people's mental health for professionals and caregivers that we deliver. We've got the Deprivation Medicine Scheme, which I mentioned on the last slide. So that is a GP trainee scheme that aims to train GPs specifically around deprivation medicine, trying to make them really resilient and equip them with all the skills that they need working in that particular cohort. And also the Healthy Gems Hub, which is a baby bank delivering the basic essentials to families, but then all that wraparound care and support that they need. And that links back in with the homeless families, because we've got some homeless families practitioners that are based in the hub. Next slide, please. So the Homeless Families was brought about by Focused Care, which is one of our sister companies, and Focused Care practitioners saw an increase in cohort with added vulnerability of homeless families within our local area. And so we were trying to reduce the adverse impact on their health, well-being and education. So we developed the Gold Standard Report, a proposal in 2019, and that formed the basis of our work going forward. So set out 4 key areas that we wanted to work on. The first was B&B standards. So when a family gets placed in temporary accommodation, they don't have the same standards as a statutory as you would have in social housing, because temporary accommodation, B&Bs, aren't classed as social housing. So there's no regulation for the standards that they're exposed to. The next was to provide focused care practitioner support for homeless families, which we've done at a local level, but would love to try and see this at a national level, because what we see is those families that are in the homeless family journey and in temporary accommodation have got that added level of vulnerability, and so we need to give wraparound support for that. actioning of the Section 2 HHSRS system, and also standardised support for children that are experiencing homelessness to the same level as looked after children. So in terms of their access to education when they're moved areas and they're not easy access to their current school, they often find that they then can't get back on the register for a school and they're out of education for a long period of time. And also that wraparound support that they get for that child following them from place to place in terms of crossing boroughs that potentially the statutory services break down for health visitors and midwives and other support services like social care as well, because they don't have anybody following that child's journey. Next slide, please. So in early 2022, we set up the All-Party Parliamentary Group for Households in Temporary Accommodation, and we are co-secretaries with Just Life. So Sam Pratt, my colleague, and also Alex Proctor from Just Life have done an awful lot of work around this. Sam is currently sunning himself in Ibiza, which is why I have ended up giving this talk instead of him, but he's done a lot of work from Shared Health side with Ishkia to be able to get us to this point. So there's currently 119,840 children living in temporary accommodation, which is just quite breathtaking really when you think of the impact that that will have on that number of children. And we initially made a call for evidence that asked for written and photographic evidence of temporary accommodation. So asking for the state of the accommodation that people were living in. We had a sense that it was substandard, but obviously without that resource, we couldn't prove it. And we got an overwhelming response of really quite appalling photos and videos that were sent from people that were living in substandard accommodation, and essentially that were trapped in temporary accommodation for much longer than they were meant to be. You know, families that had been there for 12, 18 months and that they were suffering additional avoidable hardship because of a consequence of that. Next slide, please. So I think when we're working in this field of deprivation, and particularly when you're looking at things like images and videos that have been sent to you from that call of evidence, it's really easy to get into the mindset that there's nothing that can be done and that there's no way forward. But we really wanted to make sure that we set this framework in a positive light. So the APPG wanted to prove that there is an issue there that needs addressing, but also to be able to set out a number of asks and a way forward that we can all contribute to and make a real difference at a local and a national level as well. So the APPG is going to be releasing its report in the middle of January. So it's still an embargoed report at the moment, but it has a number of key asks. So the first is for temporary accommodation to be included in the new social housing regulation bill, which I touched on earlier, because there's no current standards or regulation for temporary accommodation. Any setup for anybody that's wanting to agree to any regulations, it's an opt-in as opposed, so there isn't any standards that are around there. And then there's a 7-point policy plan that we're proposing to Parliament. The first is basic facilities and adaptation provision in temporary accommodation. So this comes around a number of different aspects, but one of our biggest asks is safe sleep for children. So we've worked with the Lullaby Trust and looking at a home away from home for children. Often a lot of families are in a position where they've either had to leave their accommodation very quickly, or they've had to flee domestic violence and they leave that morning with whatever they can carry along with their child, and they're moving into accommodation with just their bare essentials. And when a family move in there and there's no cot for their child, no matter how much education and promotion of safe sleep that we do from a health point of view, if that basic equipment isn't provided, then that child won't be able to have safe sleep that night. And so we want to see cots and safe sleep provision as a standard in all temporary accommodation. We see this at a local level, that we've had to fight for individuals. And when you do fight and you get it escalated up to management, they do provide a cot, but ultimately that could be 2-3 nights that that child hasn't had that provision. And these families have got so much added vulnerability, they often haven't got a fight left in them to try and do that without an advocate. The other is supporting housing officers. We have seen some fantastic housing officers that we've worked with, and they're working in really, really difficult situations. They often don't have very much supervision or governance around them in terms of where they're able to share all of their concerns. And so we'd offer or suggest some supervision for all the housing officers that are working with families to be able to support them in a better way. Holistic support for homeless households, goes without saying, the more that we can wrap around them, the better. A notification system. So we have modelled a notification system that is based on the police's Encompass system. And so where a family suffer domestic violence and the GP and the school automatically get notified from the police that a domestic violence incident has happened, that child will go into school the next morning, and the school are able to offer additional support, be there to support the mum if needed, or understand why the child might be upset in school, or why they might not have done the homework, and not give added trauma to that child in that moment. We want the same for temporary accommodation. So we have already modelled and tried to propose a system to a couple of local councils, and we're still working with them. So when a child enters temporary accommodation journey, there is a notification that's made from the council that goes to the GP and to the school that makes them aware that they're in that system. They don't need to give any details of the address of where they're going. It's purely for wraparound support, and we've got guidance that goes out as well to the GP and to the school in terms of what they can offer. So it might just be a case of considering whether you can offer before or after school club, or if that family have been moved 5 miles away from the school and they now need to get 3 buses to get there, to have a little bit of flexibility in terms of the start time and not penalising them for marking them late. So we'd really like the notification system to be national. Transport access for these families that are going into temporary accommodation. Like I said, they might be placed a long way away from their school, and whilst the child will get the free bus pass, you're then asking for an additional financial impact for the parent. So we've been asking Transport for Greater Manchester and working with them to try and get it so that as soon as family go into temporary accommodation, they are presented with their bus pass for the adult as well, that they're able to access without jumping through lots and lots of hoops. And then also mapping the out of area placement system. We see quite a lot of families that are moved out of area because they've fled domestic violence, which in those circumstances, there isn't anything that can be done. But there's lots of other circumstances where families are moved out of area and they're taken away from any form of support network that they currently have. And the impact that that has on families is just huge. So one of the main things I just wanted to touch on as well, which I've discussed briefly with Karen, that we can't go into too much detail because it's going to be released in January alongside the APPG report launch. But we've been working with the National Child Mortality Database to be able to look at figures of child deaths that are linked with temporary accommodation. And the statistics with that are just absolutely devastating. And so we know that the families that are going into temporary accommodation, they have an added vulnerability to them anyway, because of the natures that have led them to that point. And then you're also adding vulnerability by potentially placing them in accommodation that we know is substandard and that isn't fit for purpose in terms of being able to provide all those basic facilities that we'd ask for in this report as well. So that will be coming out in January, which when it comes out in full, I'm more than happy to discuss more with you all. But I think anything that we can get in place locally and ideally nationally will will have a huge impact for the families that we're seeing, and that huge number of children that are having adverse childhood experiences because of the temporary accommodation journey. Please feel free to ask any questions, ideally none that are too challenging.
Thank you so much, Emma. That's a really great overview. Just a couple of questions. Say, Prince, did you want to come in?
Yeah, I did. Really, that's really great presentation. I really kind of liked that. I met, it's quite interesting because I have asked about the kind of the families in temporary accommodation, people placed out of the borough, families placed out the borough. Can I just ask a simple question? Whose responsibility is it to ensure the health care for those families, that are placed out of borough in temporary accommodation?
So what we see an awful lot of is families that are moved out of borough. They often don't tell their GP that they've been moved into temporary accommodation, and they don't change their address, because as soon as they change their address, the primary care, the GP will then say that they're not allowed to be registered with them anymore, and they have to go and find a new GP, which, if you've got a relationship with your GP, you obviously don't want to lose that. The reality of the impact of that is that then the GP doesn't have any accurate recording of their address, which means the health visitor doesn't know where they're based. They don't realise they're in temporary accommodation. And the other thing is that if they're moved out of borough, they might be there for 4 or 5 weeks, and then they might be moved to another house and then another house. And so that's why they also don't want to register with another GP, because eventually they might end up back in borough, depending on why they've been moved out. So it adds an extra vulnerability, because nobody in primary healthcare knows where they are, and there isn't any official rule. So if they choose not to tell their GP, if the GP doesn't find out in terms of they're not updated by any other healthcare professionals, then they can just stay registered with their existing primary care service. But if they choose to move, and they can either register as a temporary patient at a new GP, or they can register as a permanent patient. But quite often it's also bottom of the list in terms of everything that they've got added on to their kind of plate at that time. The last thing that they want to do is to go and register at a new GP and then tell them that they haven't got any proof of address, and they might not be there.
Yeah, I understand that, but I mean, I guess ultimately there has to be somebody has to take some kind of accountability for making sure that those families that find themselves in such circumstance, that they get the healthcare they need, regardless of their kind of accommodate the circumstance, if you see what I mean. So, I mean, yes, they may be educated and well-off family, etc., and they can maybe register temporarily, etc. But ultimately, somebody needs to be checking and saying, are these families getting the right healthcare they require? Okay, and that's what I'm saying. Who's is it the healthcare? For example, in the old days, we had a CCG. So, but is it the healthcare organization from where they have come from, and or the healthcare organization in the area where they are now temporary resident? Is it a joint responsibility? But somebody has to take account. Otherwise, nobody takes account. Is what I'm trying to say.
And I think hopefully if we do get the notification system national, that will hopefully help that joined up kind of response as well.
Vicky, did you want to? Thank you, Emma, and thanks, Prince. Vicky, did you want to come in on that, or a different point? Oh, I think you're on mute still.
First time today. So yeah, it was just to speak to my point in the chat there, that the point that you've just been talking about has actually featured sadly in some child safeguarding practice reviews, where it's been a factor. It wasn't considered in those cases to be a contributing factor to the child's death, but nevertheless it was highlighted as an issue that where people are moved, they then get deregistered from the practice they were at, and like you say, it's not necessarily high on somebody's list who's very vulnerable and has loads of challenges going on that they haven't then registered somewhere else. And then if you've got babies and small children, they fall through the gaps. But in terms of Prince, were you talking about looked after children there, or families in general?
Well, I'm just relating to the presentation Emma was giving, because because for me it's about making sure that we make sure that we're kind of going to the person who's accountable and saying, what have you put in place to ensure that these families in these circumstances get the healthcare they need?
Yeah.
Do you know what I mean? There has to be somebody, otherwise all we do is we kind of leave it to the individual, and maybe a few ad hoc individuals that maybe they come across to try and navigate. But no, we have to, if there's no accountability, we just lose the track, and these families get lost.
Yeah, and there's accountability by the placing authority, but then there's also the responsibility of the authority at place where you've got people in accommodation. So there's a sort of shared issue there, but ultimately a placing authority is responsible for, certainly for children's welfare. But when they're on your patch, you're also going to take a responsibility too, and it's about that communication, isn't it, which I think has been a long-standing problem, is how you have oversight of people who are placed out of area.
Yeah, I think you've highlighted one of the main challenges there, Prince, and thank you, Vicky. Olivia, did you want to come in on that?
Thanks, Sarah. I was just going to add very quickly around the accountability, which is different when people are within a family where there are adults, because the accountability is to make healthcare provision accessible or provide a healthcare provision. And I think that the fact that the points you've made around, if people notify their GP practices, they might get deregistered, and if there is a long-standing sustainable relationship with a GP practice, if people move out temporarily, might move back in, they might not want to inform or advise that actually they've moved away, if they might be able to come back in. And as we've seen with other cohorts, if people repeatedly move from one place to the next, actually keeping that link with the one GP practice might be the better option. It's then the support where there are really vulnerable families with children, and whether there are any other agencies that are involved in supporting their ongoing access. But I think in terms of accountability, we have to, the provision of health, and if they are in an area where they need urgent and emergency care, they could always go down to the local GP practice or the urgent treatment centre. So there's two levels of accountability. There's accountability to have provision of care, which might be a tick in the box, but that might not be necessary to address the vulnerabilities of that family, but that might come under other agencies, I think.
Thank you, Olivia. And Nicola, did you want to come in?
Hi. Yes, so a question really. So I've worked previously with homeless families with vulnerable children, and sometimes they've been placed in B&B accommodation where there might be sort of adults there who have substance abuse issues, or they might have previously, just been released from prison. Is there any sort of cross-referencing with other, organisations such as the police, when we house sort of children and families in temporary accommodation?
So one of our big asks from the APPG that we're really pushing for is that singles don't get placed with families because of the absolute blatant safeguarding risk that it poses for those children and those potentially really vulnerable women that have fled domestic violence. So at a local level, we have two B&Bs that we work with really closely that are fantastic at any pushback of just saying to the council, absolutely not, this isn't happening. And at worst, they've had a single woman placed in the family accommodation, but they've reiterated that the following day that isn't acceptable. But there is the pushback from other councils is that where the need is there, they have to place them wherever. And so we want that as a blanket, just not acceptable because of the risk that it poses.
Yeah, I mean, the other risks that we found, obviously there are the risks for the families, but also in, healthcare professionals when you're out doing domiciliary visits, because it's not always possible for these families to come into clinic. you know, it's then sort of how you approach that risk as well, you know, and ensuring that healthcare staff can, you know, safely access sort of families when they're placed in these situations.
Thank you, and thank you, Emma. I'm gonna move us on, but thank you so much for that, Emma. Obviously stimulated a lot of discussion, which is great, and the purpose of today. We're going to continue that with Zoe and Tanja, who are here today to give us a health visiting perspective, so working with families and children, young people on the ground as well. So I'll hand over to yourselves. Thank you.
Thank you very much, Sarah. So I would like to introduce ourselves. My name is Tanja and my colleague Zoe. We are working for the Healthy Futures team. It's a specialist public health nursing service team and working with families with children 0 to 5 years in Brighton and Hove. Just to give you a sort of background of our team. So the Healthy Futures team was commissioned in April 2017 to deliver a 0 to 19 specialist public health nursing service, and that's including the health visiting service and the school nurse service, and to improve health outcomes, reduce inequalities and promote school readiness for families facing disadvantage in Brighton and Hove. In July 2019, the school nurse service was operationally delivered via the school nursing service, which meant that the Healthy Futures team delivered, or still delivers, the families with children 0 to 5 years and pre-birth, meeting the following criteria, such as anyone subject to a pre-birth child protection conference, if they're not already known to the public health community nursing service, a parent with a history of being looked after, families in emergency housing, including women in refuge, and who are pregnant or with a child under the age of 5, and as well not known to the public health community nursing service. Within the team, we have got public health nurses, so sort of specialist roles. One of the roles is working with young parents, so antenatal mothers who are under 18 at conception. Another specialist role is working with Gypsy, Roma and travellers families. Another role is working with refugees and migrants and migrant families housed in temporary and on-campus accommodation provided by the University of Sussex, who are pregnant or with a child under the age of 5. And again, it's if they're not known to the public health community nursing service. So the structure and the service we're providing is really, really vital, because we're picking up really vulnerable families with complex issues, so multiple issues ongoing for the family. So the team is composed of experienced health visitors and community nursery nurses, providing a citywide service, enabling continuity of care to families with specific vulnerabilities. As I was saying, sort of it could be homelessness, living in emergency housing, could be substance misuse, mental health, the child's health issues, so complex needs. And we're offering a Healthy Child Programme service at Universal Plus and Universal Partnership Plus level. So offering early assessment and intervention at the point of referral into our team, promoting a positive parenting and reducing the impact of disadvantage on families. So we have offered and developed an intensive 0 to 5 service, delivering the 5 core health visiting contacts and progressive intensive support and intervention with families across the age range, as I said, 0 to 5. The developed Healthy Futures service, or Healthy Futures team service, includes specific pathway and intervention, and also act as a specialist resource for colleagues in the Healthy Futures service, so across the city with the generic health visiting teams in Brighton and Hove. We're focusing on the health visiting high impact areas and following the integrated 4-5-6 approach model and promoting school readiness and working effectively with other professionals across Brighton and Hove. So our referrals we are getting from specialist midwives. So if a parent is expecting, we would already receive the referral around 28 weeks, and we would be offering up to 4 antenatal contacts if necessary. To build a rapport with the parent and to be able to support them. And the child would be very often already on the child protection plan. So it's collaborative working with all professionals to really be able to support that parent at best possible way we can. And to build a good and effective working relationship with the family or the parent. We would also receive a referral from the specialist midwife for substance use, homeless and travellers. Again, early contact is paramount. It's really important. So we establish that relationship, a working relationship, as soon as possible. We also receive our referrals from Brighton and Hove Children's Services if they are known to them. And again, we'll just make early contact. From another referral is from Brighton and Hove County Council. They're providing us with an emergency housing list on a fortnightly basis. And that's an update of all families, whether it would be a family who received an enhanced service, a Universal Plus, or a Universal Partnership Plus service. If the family is already known to the Healthy Child Programme, so meaning they're receiving already an enhanced service, and they have an allocated health visitor, that family would remain with a health visitor. But if not known, they would then be coming to our team, and we would make contact with them within 5 working days. And also we get our referrals from the duty line. So we're offering Monday to Fridays a service with a chat health, families calling in and inquiring about health for their child, and quite often families are identified and then allocated to us, our team, or to the generic team citywide. So as I was saying, a timescale would be once a family was allocated to us, we would make contact within 5 working days. And if the Healthy Futures team service is no longer required, or there would be step down, we would either allocate to the generic team for a health visitor to continue working with the family, or a universal service would be offered so that the family no longer requires any intervention for the time being. So just to show you and talk about the work we do, we thought we'd just sort of share a case study with you to show you the work we do in our team. So I like to talk about a case study that is a family we have worked with, is a single mother with 2 children. She had a daughter at the time, was 7 years old, and a son who was 3. They were living in emergency accommodation in a basement flat, 1 bedroom, and there was very little space to adhere COVID restrictions at the time. They were fleeing domestic abuse, and they moved to Brighton from a neighbouring county as threatened by the mother's ex-partner. The mother had experienced domestic abuse in all her previous relationships, and she had spent time in a refuge prior to the birth of her son. The children were both on a child protection plan because of domestic abuse and the mother's coping mechanism. So I was just feeling very overwhelmed as a single parent with the living conditions and their circumstances. In addition, the mother was using alcohol and cannabis and had mental health issues impacting on her ability to parent the children. And also adding to this, the son had a global delay and had a cleft lip palate repaired as a baby. The family struggled financially as there was a change to the universal credit application. So it just got the family in financial difficulties, and we stepped in and made food bank referrals for them and helped them with the application for universal credit. And also the family had very limited support in Brighton just because they only had moved due to domestic abuse. So the intervention and support we offered to the family was the family moved to Brighton towards the end of the first COVID lockdown. The first contact was via telephone, as we were unable to use the video consultation as there was no Wi-Fi in the building, and the mum had limited amount of data. Luckily, the weather was brightened and it was a good day, so we were able to meet up with the family and so were able to social distance in the park. It was good to meet up and just to be out, to be able to meet the mother. However, it was very difficult to talk openly about sensitive subjects, and because the property was too small to meet inside. And so basically what we had offered was a monthly contact, either via phone or face-to-face. And so both children were on the child protection plan at the time, as I said earlier. But the priority at the time was to help the parent to make relevant services aware of the family, and to really work collaboratively with lots of professionals together, so that the 3-year-old would receive continued care for his health needs. Referrals were made to Seaside View Development Centre for his speech and language development, and a specialist dentist because of his cleft lip. It was important to ensure that all services had the correct address, as we discussed earlier, changing GPs and frequent address, this for all professionals to be aware of where the family lived at the time, and including the cleft lip team in London, to make sure that they were all up to date with the family circumstance, so where they were living, but equally being mindful that this confidential information about their whereabouts was only shared with really on the need-to-know basis with relevant health professionals. The information given to the mother on how to access OASIS, so that supported the mother to access the right resources. So OASIS would help the mother with substance misuse. We signposted her to RISE, which is to support around domestic abuse. We helped her with the applications. We helped to make sure that she knew how to apply to the agencies, and also we signposted her to AMAZE. AMAZE offers support to families who have children with additional needs. So we supported the mother in accessing mental health. So again, just to ensure that she knew how to make contact about the referral, and which can be sometimes very there can be a delayed response, a long waiting list. So we ensured that she had access to the service. We completed an assessment of the health and development of her children. We completed the ages and stages questionnaires for her children. For the 3-year-old, we included, obviously we referred on to Seaside View. They had following assessment due to his additional needs. And yes, just sort of supported the family to access local facilities, including GPs, dentists, and appropriate nursery, and to attend appointments, just to ensuring they had the ability and the financial support to be able to use transport if needed. And we advised on the use of 111, and the GP, rather than attending A&E, just obviously if it was necessary to go to A&E, but in a non-emergent situation, to know how to access the health service. We referred to the local food bank, as the mother found it difficult to manage waiting for her universal credit to be assessed and to be changed. And also signposted her to Healthy Start vouchers and how to apply for it online. We discussed healthy relationships and the impact of domestic abuse on the children, to stress the importance for her to seek support from agencies, encouraged her to access support from RISE for domestic abuse, as I said. We liaised with the allocated social worker and discussed the family's needs, and attended call groups and case conferences for the family, wrote reports, and visited the families and assessed regularly the health needs of the children. And we made referrals to the community nursery nurse for an intervention around potty training, toilet training. So there is a whole big intervention which we do due to the complexity of the family, and trying to achieve the best outcome for this, for all our families. But this is just sort of an example of the work we do.
Absolutely. Thank you, Tanja. That's a really great overview, really helpful to highlight some of the complexities of the families that you're supporting every day. What I think we might do...
Oh, sorry, it's Zoe. I'm Tanya's colleague. I was just going to complete the presentation, but are we a little bit over time?
We are a little bit over time. Do you mind if we come to Hannah, just so we've got time to share Hannah's as well? And then what we'll do is we'll come back to questions for all three of you, if that's okay. Fabulous. Thank you. Sorry to cut you off. I know it's only an hour and a half, and we went over time really quickly, which is my fault. Terrible chairing. But Hannah, are you ready to jump in? Hi. Thank you so much, Hannah. So Hannah's joining us from Career Matters to give a perspective of young people facing care and the pitfalls for them around employment and homelessness. So I'll hand over to you, Hannah.
Thanks so much. Hi everybody, good afternoon. My name is Hannah Kirkbride. I'm Director of Career Matters, and really excited to be here today to talk to you about care experience young people, their experience of homelessness, and some of the different projects that we're doing you might want to get involved in that are solutions to making things a little bit better for these young people. So I'm conscious we're short on time, so I will whiz through this to hopefully give a chance for some questions. So Career Matters is a social enterprise, and we work with communities who are most removed from traditional pathways into education, employment and training. We're made up of a team of experts across education, careers, social care, health and industry. And I think it's really important to talk about our story. So why do we do what we do? I'm supported by a diverse team of professionals, many who have lived experience of the care system and or the criminal justice system. And also we have lived experience representation at leadership level within our organisation. Lived experience is a golden thread through all of our work. And I also established Career Matters in 2016 as an individual who's been through the care system, navigated the challenges that people face in doing so, and felt that there's a lot of things that we could do that could make the situation a bit better. So if I could have the next slide. I know I'm having help with this today with my slides. Thank you so much. So these stats, I think it's really important to highlight the statistics affecting these young people. And I'm happy for these slides to be shared with everybody after this session. So they're a little bit depressing, but don't worry, there's a lot that we can do to make things a bit better. And on homelessness, the ONS data recently showed that there were 13 reported deaths of homeless children aged 15 to 19 in 2021. And also it's important to know that a child who's in the care system is sadly 13 times more likely to end up in the criminal justice system through criminal exploitation. Research from Home for Good states that care leavers make up 25% of the homeless population, and they estimate that 17% of young people who are eligible for leaving care support go on to make homelessness applications. So I've been out and spoken to hundreds of employers about the disconnect between opportunities for care leavers and their ability to access them. And why I think jobs are so important is because it enables somebody to be autonomous, and it enables them to bring themselves out and sometimes of the systems that are failing them. So NEAT figures stand at 41% for 19 to 21-year-olds, and the national average is 11.6%. Only 17% gain 5 GCSEs compared to the national average of 60%, and around 10,000 young people leave the care system every year. 2% go into apprenticeships, and they're excluded from apprenticeships because the apprenticeship wage is so low, £3.90 an hour when you're living independently with no financial support networks is not possible. 12%, worryingly, of our most vulnerable young people who leave the care system, their whereabouts are unknown to the corporate parent. This is an area that we spend a lot of time working on, and we're doing a lot of work to improve those young people being in touch with us and the services that are there to support them. And when we talk about health inequalities, for this community, they're significant, with 70% of care leavers who are likely to die prematurely in comparison to the rest of the population. And as I mentioned before, care experienced people are overrepresented in the criminal justice system. 27% in the adult prison population and 50% in the youth justice population. I have put some additional links in this presentation. At the end, there's a whole load about reform. So if you're interested in exploring this further, there is information for you on that. But York University did a really interesting piece of research. So a young man going through the care system and ending up in the criminal justice system will cost £1 million to the state. And a female whose children will also be taken into care when she goes into prison, for example, will cost significantly more. So, as I said, not very exciting stats, but shows that there's plenty that we can do to move forward. And I've added in some criminal justice stats as well, which I won't go through in great detail today. They'll be in the slide pack for you. But also with that high representation, I think it's really important that we understand that many of these young people are going to end up in the criminal justice system too. And on the next slide, a visual. So, you know, the plan for leaving care and the bottom bit, which was actually my reality and many young people who go through the care system's reality. The care experience often is directly linked to adverse childhood experience and the resulting complex trauma associated with it. Broken bonds, traumatic experience do not build up the foundations for good mental health or the ability to move forward into fulfilling and happy futures. Early life traumatic experience of adverse childhood experience compounds for many into complex post-traumatic stress disorders. And many children face difficulty in accessing mental health services because of moves, instability in life, and many do not get access to mental health services, for example, until later in life. I always pose the question that why is mental health support not available at the point of a young person going into the care system? These children face continual moves throughout their young life. Some have numerous placements, and those who pose a risk to themselves and or others due to their mental health and traumatic life experience also face having their liberty taken away. So children reach a cliff edge of support in the care system, and this can hit at 16, 18, 21 or 25 years for others if they're lucky. These young people are often unprepared for living independently and face housing crisis and a lack of support networks. Why are these young people ending up homeless? A lack of networks and finance. They're not receiving their statutory entitlements through their local authorities, and we as an organisation help to advocate to ensure that they do get their basic entitlement. And also it's important to think about what's coming down the line from a health and corporate parenting principles. So there's been a recent independent care review, and there are 80 recommendations within that, and one of those is around there being a shared corporate parent principle across all anchor institutions across the country. And some of you will be aware of the recent change in legislation for unregulated accommodation for 16 to 17-year-olds who are in the care system, of which I sit on an expert panel with Ofsted in the Department for Education. It's an interesting one because it only protects 16 to 17-year-olds, and it is currently under consultation. I urge you to read the Department for Education's consultation, and if you have an opinion, please submit your opinion, of which it is varied. Somebody touched on earlier about accommodation with people who've been released from prison and one of the suggested forms of accommodation for these young people would enable that to happen, which is extremely concerning for me. If I could have the next slide, please. So what can we do about this? So there's loads of good things that we can do to make the situation better for these young people, and Career Matters has brought together a network of support around health inequalities, education, employment and training. And we've created a platform, a virtual and physical platform called Thrive. And that through this platform, referrals for support for young people to a range of multi-agencies in geographical locations across the country can be provided. That gives you an example of some of the organisations that are involved, and I'm also going to give you the opportunity yourselves, if you're interested, to get involved. If I could have the next slide, please. So this is our Thrive model of support. So a young person can be referred in individually through HMP, local authorities, community or other, and they will receive a range of support through the system. So we provide qualifications, peer support, we advocate, as I said before, and critically, we're a career development organisation, so we help them think about what they might be good at in the future. We help them look at employment, and we also help navigate and help them broker that employment opportunity for them, with the NHS being one of our largest employers with skill shortage requirements and this incredible pool of untapped talent of these young people who could bring so much to the NHS. And we refer to multi-agencies, and the outcomes of our work, we reduce health inequalities by creating fulfilling lives. We create jobs, education, employment and training, and critically, we provide that network of support, and we provide peer support. So we have positive representation in our organisation, and it's really helpful for young people to be able to meet people who've also been there too. And on the next slide, we've brought together an action groups ecosystem. So we would like to invite you to join this if you are interested and want to get involved in the work that we're doing. and the change that we're hoping to make. We've got 3 different groups: technology, because we are tech developers too; lived experience, because it's really important to have their voice and also that equal balance of power in decision making. And then we have our multi-agency group, which is where many NHS and wider social care organisations sit. And alongside that, we have our steering committee with representation from all of the government departments, Department for Education, Ofsted, Health Education England, NHS England, and more. So we have substantial support and buy-in, which is incredible. And then I'd also like, on the next slide, just to give you an overview of one of our other projects that we're running. So the Thrive platform is about supporting individuals and organisations working with them. But what we found in our research is that many employers want to do something to help, but don't know quite how to go about it. So we created, we were commissioned by NHS England, and we created, through co-production and co-design, the Lived Experience Charter, a really exciting project, currently rolling out nationally across 24 sites. And it's basically a toolkit to help employers create a more diverse and representative workforce. The Independent Care Review has a recommendation that the NHS could or should, under their corporate parenting principles, have a 0.6% representation in your workforce of people with care experience. So this solution to help. So why the Lived Experience Charter? There are requirements in service specifications such as Section 7A public health regulations to have lived experience involvement, and there's a commitment under the ICS-ICB systems to ensure co-production and user voice. You've got skill shortage requirements across the NHS, and these are an untapped pool of talent who could be supporting you. And it's a meaningful way of supporting and enhancing service design, delivery, and an ability to connect with the communities that you seek to serve. So organisations take part in the charter, they go through an application process, and they will be awarded a different level of status in the charter process. On the next slide, I've put the charter values, but I won't go through that. You can have that, and it would be really good for you to have a look and see, is this something that you're embedding in your organisation or something that might support your organisation? And on the next slide, I've just given a diagram of what's involved. So at the top, you would have the employer organisation, you'd sign up to the values, apply for charter status, you'd get training, and then you would be awarded. And as I said before, lived experience runs through everything we do. So we have a multidisciplinary assessment panel of up to 22 now are on that panel, made up of half representation of lived experience and half representation of a multidisciplinary organisations as well. And on the next slide, I've just given you an overview of who the pilot sites are. I think this is the earlier slide deck, and on the next slide, all of the organisations that are participating in the charter. I've highlighted the children and young people. Please could I have the next slide. So nearly finished. So how can we help each other through this process? So one, you can join our action groups, and this slide deck will be shared with you. Please feel free to inquire or join the action groups. Just get in touch, we'll set you up. You could apply to the Lived Experience Charter. And so I've put in a couple of additional slides as well, contact details and reform information about what's happening in this space now, what's coming down the line. And I wanted